We have a quorum.
Joby, can you turn on the camera?
Wrong with my camera. It's on, but can you see me? This is Linda.
No, we cannot see you.
I have it on, but then I don't know what's going on.
Hey, Linda, sometimes our laptops at the end here, there's that little switch right above the camera lens.
Yeah,
Check that.
no, I just turned it on. I had trouble with my camera before, but at least the light's on. It says it's on. Let me see. Appearance. Right. I'll go out and come back in. Maybe, I don't know if that would do anything, but.
Yeah, we have a quorum without her, by the way.
That's fine.
So,
Right there. Give about another minute or so. Yeah, there we go.
There we go.
All right, so it is 9:02, so I'll go ahead and call this meeting to order. Mr. Secretary, do we have a quorum?
yes, we do.
Great. Next item on the agenda is the approval of the agenda. I would like to make one addition. I'd like to add right after approval of the minutes, discussion with Heritage Bank regarding our reserves.
Make that motion to approve and add the addition.
And thank you, Harry. Is there a second?
First responders say they hold several people from home.
All right. Mayor Adams. All right. All in favor, please say aye.
Aye.
Any opposed?
Oklahoma.
Okay. Let's see. All right. So now next item is the approval of the minutes.
I'll make
that motion.
Second.
Okay. Second, Terry. First, Terry. Any discussion or changes? Hearing none, all in favor, please say aye.
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 Any opposed? Okay, aye for Terry. Right, great. So now we'll go ahead and turn this over to Mr. Tom Taylor from Heritage Bank to discuss.
Hey, Craig, before we move on, you have somebody has a conference call or another phone conversation going on, and I'm hearing that through this meeting. Are you all hearing that?
I am.
I am. Yeah, no, I am. So trying to look through.
Could somebody please stop that call or put it on mute?
Yeah, I'll watch the microphones. I'll watch the microphones, see what I can do. All right. So next up is Mr. Taylor. Mr. Taylor, how are you?
How are you today?
Good.
Well, I was asked to come in and just basically give a little presentation. Apparently, there are some additional funds that the board has, and I know Heritage offers interest rates, but I understand that we're not earning very much on the money. So Harry asked me to come in and just kind of talk and answer some questions, but we have a lot of municipalities that we deal with and essentially do the same thing. There's extra funds that aren't needed for a certain amount of time. My job is to essentially make them work. I use treasury bonds instead of like the bank products. We use Ameriprise as a brokerage service to offer these things in conjunction with what Heritage has as well. So everything discussed here, obviously, we are fiduciaries of everyone's money. So obviously the conversation is going to revolve around priority number one, safety and growth. So really that is the whole agenda today, to kind of talk about what's available, what we can do to make a little bit of extra for everybody and keep the money safe. With that, really, it's just I'll give an example. We have another municipality where there is a fire truck being built. We're using about $2.5 million to do that. I had no idea that they were that expensive, but I'm learning along the way as well. So piecemealing out, their conditions are when they need certain amount of funds, say, okay, 400,000 within 3 months. We use a three-month treasury bill to earn as much interest as we can. That matures, we go ahead and allocate those funds to the fire truck, and so on. So that's kind of a prime example of what our capabilities are. We can ladder money, we can keep money as liquid. So really, I'm here just to kind of answer questions and find out how I could be of service and how I can make more money for you guys. And obviously, like I said, keep it safe.
Great. No, thank you. So obviously we have our main operating account through Heritage. We also have a secondary HRA RX account that we use for prescriptions that aren't covered by our plan. As an existing Heritage Bank customer, what steps do we need to take in order to take advantage of some of this?
Logistically, what normally happens is there's a couple of different authorized signers on the account. You guys determined who those would be. We would open up an account mirroring the registration of the accounts already held at Heritage with the authorized signers obviously on those as well. At that point, I can come out and literally open them up with a signature on my computer screen, and everything is in order. I like to link bank accounts so that I can toggle money back and forth when needed. My whole thing is to keep everything as simple as I can and flexible. So again, you determine who those people are. I open up the account, do all the work for you, and you essentially tell me how much money you want to put in and how long you want it to work for you.
My question would be, Craig, what kind of return are we talking?
Well, I think that would depend upon the market, but I think treasuries right now are paying probably double than what we're getting in our current checking. Tom can speak more to that.
I don't know what we're getting right now. That's what I'm saying. What kind of figure are we looking at as far as a return on that money?
We're about 1.8 right now, I think.
Really?
Yeah.
Have we shopped around? Because I know here at the county, I'm getting quite a bit more than that with my local bank.
Right. We have one $240,000 CD at Fifth Third that's at 3, and that's all we got right now.
Yeah, 1.8 is what we're getting on the just a straight checking account.
Mm-hmm.
Right.
How much is in that checking account, and how fluid do we need it, or how liquid do we need it?
There's approximately 2,087,000-ish in the main checking account right now, and we have no use for it other than we have to, we're about to vote to send some money to Jefferson Health Plan, right? So that'll be some of it. We don't really have a use for those funds other than to make us money.
Correct.
Is that what we pay our prescriptions that are not covered by the plan? Is that the account we pay those out of?
Not anymore. Those are now being taken care of by Jefferson through a separate HRA account at Jefferson Health Plan.
So would it make sense after we decide how much we're sending to Jefferson Health Plan that we pay them? And if we don't need this money again till next year, per se, when it's time to pay them again, go ahead and lock that up on CDs, because CDs tend to be more than a normal checking account, if it's something we don't need at any given time.
Yeah, I think
Mayor,
so. Go ahead.
Mayor, I was going to say, absolutely. And that's kind of why I reached out to Tom, because even with CDs, I think that like money markets or treasury bills, we could make more off of that. I think we had discussed last meeting that we're going to pay Jefferson Health, what, 200,000 to completely fund our reserves with them and take that out of the payment. And then after that, I think that if it would be my thought process to allow Tom to be able to manage those funds, whether it's through T-bills or whether it's through money market or however he sees fit, to make us the most return on investment, to be able to capitalize that and pay our operating expenses.
Right.
I agree.
Right. Because we have about $28,000 a year in board expenses that are really, or do not roll through either MedBin or Jefferson Health Plan. So,
Right.
And that's for our protection as a board, mostly for the insurance and the financial bond.
Right.
And the admin fees we pay for the great services we get from the area development district. So, yeah, doubling that would be really good, because right now we're about breaking even. We're earning about enough to pay for everything, but that doesn't help us grow. And in the past, this fund would grow because we would have good years, right? We would
Right.
raise our insurance, we would pay ourselves, and then the claims would come in lower than what we budgeted, and then we bank the money. Well, that's no longer the case, because now that money's going to Jefferson Health Plan and building that reserve account over there. So I think this is a good move. Yeah, so we mentioned that the return would be bigger. About how much would that return be in your estimation, Mr. Taylor?
Well, I just was looking. We have new inventory every single day, but it's been holding steady. There probably will be a change in the near future. Obviously, we're seeing a new Fed chairman go through right now, and as soon as that happens, I would imagine the rates are going to be dropping. But our timing is good. So with all that said, right now I just looked at somewhere. It really depends. I mean, if you say like a year, we're looking at 3.2, 3.3, somewhere in that ballpark. And I know if the funds are in a checking account, obviously you're not earning anywhere close to that. We're talking $65,000 in earnings versus a few pennies that you're getting now, maybe 4,000 versus 3.2. Long answer.
Okay.
I guess we could diversify. We've got the 2 million, but could we have something a little longer term that would maybe give some more interest? And that, like, okay, we can dedicate, say, 500,000 or 750,000 or whatever it may be to a longer term, or are we going to try to just stick within that fiscal year?
Oh, Paul, with it being the ability to ladder it, we could do that for sure. I mean, like what I do with the water district, I've got some that are 6 months, I've got some that are 18 months and 3 years. I mean, a few of the 3-year ones that I currently have is like 4.5%. So, with Tom's expertise and in the board's direction, he'd be able to do the same thing.
Okay, and it's typically like a locked in, say that 4.5%, that's locked in, but we just have to dedicate that money for the next 3 years or 2 years or whatever it may be. Correct?
Correct. Yes,
Okay.
correct.
Yeah. And I will make a statement on that. If the need is there for some reason that you said, okay, well, we're tying money up for a 3-year time period, and for some reason those funds were needed, we literally can go in and essentially sell back the treasuries to someone else. And based on what I was just talking about with the Fed really kind of cutting rates, I use an example. If we can get 4.5 now,
Tom, I think we lost your audio.
Sorry.
Yeah. Lost you, Tom.
And then, oh, can you hear me?
Yes.
No, yes.
Oh, am I back? Okay. You said that the likelihood of being
Lost him again.
Sorry, Tom, can't hear you.
able to
Yeah, when Tom starts talking about money, we lose him. What happened, Tom?
no, I know. No, I got to go make some more. But no, no, all I'm saying is we can have that. They're very, very liquid. The likelihood that we would actually make money if we sold in the future is high because the rates are going to be dropping. So just making that point. But we can literally sell a treasury within 2 seconds. Everybody needs these things, and they're 1,000% guaranteed. So we're going to be safe no matter what we do.
Okay. Yeah, that was my next question as far as the security of this. So it's relative, I mean, it's guaranteed money then, as far as that
Oh,
percentage.
most definitely.
Yeah.
This is actually even
Yeah.
higher
With T-bills, they're
for coverage. Yeah,
Okay.
So would the board be okay if Harry and I, because I know Harry's the second signer, at least on the HRA account, and I think we need to get a new ad person on to some of the other accounts. Go ahead and would everybody be comfortable if we at least start moving 1.5 million into these now before there's changes in the rates?
I'd make that motion.
Okay, I got Harry.
So we're clear. So 1.5 million, you say, to move over to Heritage, and that the whatever's the remaining, that's going to give us enough for this year for whatever. Because I know we haven't discussed the buy down and on premiums this year, and then also the reserve that would be transferred over to JHP. But that 500,000 plus is going to be more than enough for that, correct?
I believe so.
Okay. Yeah,
So
I'll second.
All right.
Quick discussion.
Motion made and seconded to work with Heritage Bank to invest $1.5 million. Any discussion?
Yeah, so is that, are we looking then at how long, at least a year? Is that what we're thinking? Are we looking at the layer or is that something to come later?
I think we are looking at a latter situation where we'll take we'll ask Heritage Bank so now that they know how much they're dealing with to make a proposal back.
Okay.
You know, we meet again in June, but I think with Harry's, you know, and we got Peggy and we got a couple other treasurers, so it's like we have expertise around. We can float that schedule around really easy and make sure everybody's comfortable with it.
The only other question I have, is there any cost to us in them investing this?
those figures. Yeah, when we originally buy treasuries, there is an initial cost. Every number that I'm talking about is after any costs or fees. So we would be netting out 3.2 if we went for a little less than a year, longer. Yeah, so those are net figures.
All right. Any other questions or discussion before we call? All right. Hearing none, all in favor, please say aye.
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 Anyone opposed? All right. Great. Thank you, Mr. Taylor, and thank you, Harry, for making these arrangements, and we'll be in touch.
Thank you, Tom.
Everyone have a great day. I appreciate it.
Thank you.
Okay. Thank you all. Great discussion as always. Next item on the agenda is the financial report.
Chris, can you give me permission to share?
You should have permission now.
Okay, thank you. All right, can everybody see the report?
Not
Not
yet.
yet. Okay. Try it again. How's that?
Yes.
Okay. All right, so this is the financial report from July through March, so first 3 quarters of this plan year. And you will see that you've had in-network medical claims of about 2.7 million, out-of-network medical claims of about 759,000, pharmacy claims of about 715,000, specialty drug HRA claims of approximately 79,000. Your fixed costs are right at about 1.1 million. So your total plan costs before any reimbursements are 5.3 million. Through March, the premiums from all the entities were about 4.8 million. And so prior to stop loss reimbursements, that's a negative 569,000. Your due stop loss reimbursements of about 324,000. And so the net plan cost then is about negative 245,000. You have earned interest within Jefferson Health Plan of about $1,300. The PCORI fees were about $1,600. So net plan cost after you factor in those things, again, about negative $246,000. And then looking at the legacy reserve, we started the year with 2,077,000 and some change. And to that, we can add in the buy-in fees from some of the newer entities of about 26,000. Fees that the fees that Craig described previously that are related to the board, about 24,000, and interest of about 32,000. So the balance through March in the legacy reserve is about 2.1 million. And RX rebates are included in the claims that you see here. They're netted out before the check runs go out. So that is the financial report. Any questions?
Okay.
All right.
If there's no questions or discussions, thank you. We'll move on to the MedBin plan update.
Real quick for.
Yep. Go ahead.
There I am. On the agreement that we're going to be doing later, interlocal, does it say something about people buying in and whether they get a vote and all that other good stuff? Is that they have access to our money? Somewhere in there, I was reading that.
So I intended to have that discussion further down the line, but
okay, that's fine. Yep.
But to answer the question up front, it depends.
Okay.
So there's an opportunity for people outside the area development district area to join if this interlocal is adopted, and they definitely would not have access to those reserve funds. If there's a chance for new members inside the local area development district to join, and they would have a choice. They would have a choice whether they wanted to join with the buy-in, and at which point they would have future access to that reserve, or if they decided not to buy in, then they would not have access to that reserve.
Okay, so buying the lease is talking about are people that are inside the ad district list. Okay.
Yes.
Thank you.
Okay. Great. So now we're up to MedBin plan update.
Right. Good morning. I'm going to be doing the MedBin update today. It's usually Brooke Hupp, but she's on the road, so I'm going to try to share my screen here. All right. Can everybody see that? Is it too big? Too small? Okay. Okay. So please let me know if you have any questions. These reports over the years have really grown. So I think we're at about a 55-page report. We can share with everybody. I'm just going to kind of summarize it, and we're not going to hit every page. We'd be here forever, and it's Friday. Okay. So first thing I'm going to do is I'm going to go over where we're at right now as far as how your report is running. And we're going to do a 5-year look back on this. You can see we're going to start at the 2021 plan year all the way through right now. Up at the very top, you notice there's the average number of employees and members. You guys are up this year for the first time in about, well, I shouldn't say the first time, but about 5 years. This is the largest group that you guys have had. Obviously, we brought in some other entities, so that's always great. Your plan is running fairly well. You do have right now, if you compare it We are looking at a rough annualized about 5 million, a little over 5 million in medical and RX claims. Would put you at about a 5% increase from last year. Keep in mind, again, we've got the new entities on board as well, so with more members. We're looking at if we look at your per employee per year, your plan paid, you're running about $10,000 per employee per year. Pharmacy is about $2,000, a little over $2,000. If you want to put those together as your net, you're looking at about $11,600 per employee per plan year paid. That's going to keep you basically, if we look at your rough annualized at $14,803, really you're at a 0% increase as opposed to where you were last year. If you look back in 2023, that was a big year for you guys. Obviously, there was large claimants took a hit on there, so it's good that we're trending in the right direction. Total net claims and fixed costs. This is looking fairly well as when you're doing your look back. Last year you were at 17, or about 18,000. This year you're looking at about, if we do the rough annualized, we're looking at about 18,000 as well. So about a 1% increase isn't bad though, considering that we've got more members, more people on the plan, more claims. I'm going to go down here to your, I'm going to scroll this, your financial dashboard. So when we look at this financial dashboard, what we're looking at is your claim count, kind of our benchmark is where we see across our block of business. So our benchmark rate for admissions is $594,000. You guys are looking at about $480,000. You've got 3.5 in medical claims and about 800,000 in pharmacy claims. We will touch a little bit on your pharmacy claims and where we're seeing an increase in that. Again, specialty medications, things like that often will jump that up. Average cost per claimant again is about $5,287. Average claim cost is about $423. So you can see here where your paid claims, your claim count by month. September you had a spike. Last year kind of back down a little bit. And then, back up in January. So we kind of see this across our board. I'm going to go down to the next. All right, we're going to look at your health plan snapshot. So when we're looking at this, we're going to see that total membership has increased by about 7.23%. Again, that's going to bump your guys' numbers up a little bit. You're going to see outpatient. The reporting period right now is in our blue. Comparison is in the mauve color, the reddish color, and your benchmark is going to be in your gray. So you're going to notice that you are seeing an uptick in your outpatient, but you are at a tad bit above our benchmark. You're going to see office visit roughly about the same. And again, this is going to break out where we see our members going. Inpatient, your outpatient per member per month, your office visit. And we're on my next slide, we'll kind of touch base on where we're seeing members go for their appointments and how your guys' plan is looking. I'm gonna, and like I said, this has really grown this report. So we're not going to touch base on everything, but if you see something you want me to stop and you want to look at, we can. All right, this kind of breaks down your coverage tier. So this is important. So looks like you've got employee and spouse. This right here is going to tell you the number of subscribers, members, family. So obviously you've got a lot of employee only. You've got family options, employee, spouse, and this is going to break down your members, what you guys are seeing paid per claim or per tier. And that's just good information because a lot of people are like, well, do we have many employees? Do we have family? Do we allow spouses on the plan? Do we not allow spouses? So that's always good information, when we're looking at a health plan to kind of see where we're at moving forward. Top hospital providers. This is always a big one. Obviously, it's St. E's. The next slide below it is comparing to last year. So this year you've had St. E's Medical Center. You paid about current period about $800,000. You've got 295 claims with 122 members going there. Next is going to be your Children's Hospital Center. And then your St. E's Florence, St. E's Fort Thomas, and the Christ. When we look at compared to last year, you had the St. E's Medical Center again. And overall, that's where most people utilize it. Good Samaritans in Evandale, and then Children's Hospital was your third. So there's a little bit of change on your top hospital providers and your current period versus your last period. You have had 17 inpatient admissions. 8 of them have been medical. You've had 6 surgical and 3 maternity. So we do like to kind of touch base on inpatient. Do the inpatient stem from ER visits? Inpatient, are they plans? Again, obviously you've got your 4% of medical, or your average length of stays or days was 4.1 medical, for 4.2 days surgical, and 2.3 maternity. This is great news. 29% of your admissions originated in the ER. So I know that sounds like, well, why is that good news? Well, people are utilizing the ER and for emergencies. So obviously, you're going to see on the next couple slides that we talk about people who go to the ER who don't have a true emergency. And 29% of your admissions did originate from there. Your outpatient imaging, you've had 148 scans, you've had 90 MRIs, 173 CTs. You are above our benchmark in our CT scans by about 27%. That's okay. People could be getting them for all different reasons. Obviously, you've had an uptick in also your inpatient stays. So that would make sense on that. You've had utilization. Children's Hospital Medical Center you've had the 4 MRIs and 3 CTs. And you can tell the cost comparison, obviously, when you specialize as like children's, $33,000 for 7 scans, MRIs and CTs. And whereas if they would go to St. E's for substantially bigger savings at only $30,000 as compared to children's. So again, sometimes that can just be, do the children's MRIs and CTs need to be done at children's, or can they be done at St. E's and then, taken to children's? It kind of depends, if they want them done there in-house. So that, also we can look at those dynamics. Here's your ER. Again, you had 2 members who had 6 or more ER visits. Not a huge amount. And we can always, discuss who they are for maybe some more patient education as far as utilizing a primary care provider instead of going to the ER. Obviously, we know ER visits are expensive. 10% of your ER visits were potentially avoidable. So you're a tad bit over our benchmark for visits, but then again, sometimes it is just a member educational piece where we just make sure that people have a primary care provider and utilize that accordingly. Your most common diagnosis was a cardiac disorder, and your most common avoidable would be back pain, about 42%. So maybe after hours, someone hurts their back on the job, things like that. And those would be the ones where we'd want to, see if they're going to an urgent care if they have a PCP for your back pain. I'm going to go through a little bit of this ER. There's a lot of slides on this ER.
Hey, Amber, can you stop there on page, go back one more.
One more?
That one.
Okay.
I want to highlight, because we're going to make a recommendation about ER copays.
Okay.
That you had 8 members who went to the ER 2 times. You had 3 members, or 4 members who went 3 times, 4 members who went 4 times, and 2 members who went 6 times. So there are a lot of people who are going to the emergency room multiple times.
Yes.
And so that is going to have a bearing on our recommendations about emergency room copays.
Okay, perfect. Thank you. So any questions on this ER visit while we're moving forward? We'll visit with that, like Lisa said about that.
Just real
Okay.
quick I'm sorry about the ER visits. I mean,
Yeah.
all of those have been paid claims, correct?
Correct. Yes.
Okay. Do we know like how many are denied?
I don't know how many are denied. I mean, I could go see if there's any denied ER claims. I could pull that.
Yeah, in this report, they're only showing paid claims.
Yeah.
These are all paid. Okay.
Yeah. But I can run a report and send it over, Paul.
Okay. It's just we ran into that issue, here. It's been sorted out, but I've just with some of these, as far as the severity goes, I just didn't know if there were certain stipulations that were in place for a denial or if the majority of them were paid. And sometimes there's just an anomaly. So.
Right. So, and I know you and I kind of worked on an issue that we had, and it was deemed not a true emergency. Therefore, the claim wasn't, I don't think it was processed. Once we went back in and kind of looked at it, I do think that there is, when our claims examiners are looking at it and they're seeing ER claim, they do look at it for as a true ER emergency room visit. So that's a good question. Let me run a report and just see what I can find on that, and then we can share it if we see that that's,
Sure. And it's not that I want any of these to be denied because I've been in the situation. I've got kids, it's like you're presented with a situation at the time it's an emergency, right?
Yeah, sure.
But I just, as far as like that evaluation of that, whether it's paid or denied, kind of what that is, and it's just kind of universal across the board, or is it sometimes a subjective, view from a particular doctor or, what it may be.
Well, I can definitely run a report. I know on the one that you and I kind of worked on, it was the doctors had said that they didn't feel it was an emergency. Kind of the notes that were submitted didn't match that it was emergency. However, once we really delve into like what was happening and discuss the situation, I think that kind of changed how we looked at the claim. I don't know for sure. I'll pull the stipulations on when they deem it a true emergency room visit as opposed to not. So that's a good question, Paul. I don't know the answer right off the top of my head on that.
Okay, no problem. Thank you.
Yep. Okay.
I have a quick question. What is the benchmark? I mean, how is that established? The benchmark, is that coming from states across the country, or is that benchmark based on something that's mid-south or southeast? Or
so the benchmark is based off of our entire block of business. So when we look at all of our groups as a whole across all of our different regions, we take that, and this report will annualize that out and give us that benchmark. So it's I don't want to say so we've got our region here, we've got some other states, Indiana. We take all of these visits and this reporting takes all of that information, and then that's what sets our benchmark.
So the regions, are they more Midwest
I would say absolutely Midwest. Some smaller groups here and there. But yeah, definitely a Midwest benchmark. I suppose, it'd be crazy if we pulled in, if we went to New York or, we had some groups there.
Yeah, that's all I was curious. General.
More of a Midwest. Yeah.
Thank you.
Now, can you guys still see this report? Or did it click off? You can? Okay, very good. Okay, let's look at, here's our shock claimant reporting. So this is always interesting. Everyone wants to see where they're at as shock claimants. Right now, you guys are running fairly well on your shock claimants. You've got 38%. So this is this time period, and the screen below it's going to be last time period. So we'll discuss that. So right now you've got your threshold. You've got about $42,500 in paid. Your threshold shock claimants. I'm sorry, you have 18 shock claimants. Your medical and RX shock claimants, you've paid about $1.6 million. and your medical and RX paid other claims, you're at about 2.7. So when we're looking at our shot claimants, there's a couple of things here. We look to see if the member's terms, if they're active and employee dependent, and where they're at as far as their overall care alert score and their prospective risk score. So right now you have an active employee who has cancer, and for anytime that we see a high claimant, shot claimants, we want to kind of see where they're at on this. So we do see a prospective risk score, and what that does is that utilizes the medical claim history that we have on file, and we predict like the risk score for each individual for your next time period. They represent the predicted health status for a 12-month projection. So you're going to see that some risk scores are higher. It could be that maybe they're a newer diagnosis. Some are lower. Maybe they're further along into their treatment cycle. Termed, obviously, you've got a couple of terms employees. You've got a dependent on here. So what this does is just tell you where you're at as far as your high claimants, your shot claimants. You do have quite a few more this year than you did last year, and we can kind of look at compare that. Lisa, were you gonna say something?
Yeah, I was gonna say when you look at the risk scores for the 18 individuals on this report, 15 of them have improving risk scores, which generally bodes well for the plan, because typically claims follow what that risk score is doing.
Yeah, so you do. You've got quite, and like Lisa said, I mean, you've got numbers that are really going down, which is great. So yeah, 18 individuals. Last year, you had 12 shot claimants. So you do have a jump this year in as far as your shot claimants go. This is just a utilization dashboard. Again, it's your kind of breaks it out, your plan. You can see it's emergency room visits up here at the top. You're going to see exactly what your visits were last year as opposed to your ER visits, your severity, your days that people stayed, your outpatient imaging. So this just basically gives you a graph of what we've discussed previously. Utilization metrics. There's one here that's for, I don't want to use this per 1,000. Let's go down a little bit. Okay, let's, if we look at your chronic conditions utilization, this kind of breaks down where we're seeing the majority of claims and how it's broken down. So in our reporting period, this is going to tell you exactly, are you seeing rheumatoid arthritis, liver disease, ADHD is high, you've got psychosis, asthma. So this really breaks it down and tells you like, where are we seeing our claims at? You've got diabetic claims, you've got chronic pain. So this is our benchmark, like what you have now, as opposed to our benchmark, and kind of where your claims are going to run based on your chronic conditions. Cancer dashboard, just because you do have shot claimants, this is going to tell you you've got 17 members diagnosed with cancer. Your average age of your cancer patient is 51 years old. This is kind of hard to see. I don't know if you can really see it. You're going to see that 81% makeup of the employee is your cancer prevalence based on your relationship, where about 18% is spouse. You've got a majority, 62% are male, 37% are female.
And Amber, can I just interject here? Yeah, so you all saw on one of the earlier pages of the report that your outpatient claims were up this year. And one of the reasons for that is because you've got people with cancer who are primarily getting their treatment in an outpatient hospital setting.
Yep, absolutely. This right here is going to tell you where they're utilizing or getting their treatment. So it's kind of small. You've got St. E's, and then your St. E's Medical Center, and then your St. E's Florence, and then there's a couple other providers there. So I think it's 93% are utilizing St. E's for their treatment. Diabetic dashboard. When we talk about this, a lot of times we bring this up because this this adds to your RX spend on your account. So you've got 72 members that are diabetic, potentially undiagnosed about 3. You do have your about 70 people do see their provider for it. We've got 28 high-risk diabetics. So we want to make sure that we're really pushing them towards going to their PCP, making sure they're getting their wellness, their checkups as they should. You will see, let me see if I can make this one a little bigger. All right, so you do have your number 1, here's Mounjaro as far as what your diabetic members are utilizing. You will see that you've got 111 scripts for the Mounjaro, and then your next is going to be Ozempic. So we do have it set up that you do have to have a diagnosis of being diabetic in order to get the GLP-1s, and that's just how your plan runs. So what happens if a member goes to fill Mounjaro or let's say Ozempic and they don't have the diagnosis as being a diabetic, a type 2 diabetic, they will be denied at the pharmacy as a plan exclusion. And that's to keep costs down. Obviously, we know that these GLP-1s can get pretty pricey on plans. And then we've got your well living. We will run an updated one probably maybe in June just to see where everybody's at. But right now you've got your blue is your compliant and your red's your non-compliant. So you're looking pretty well on your cholesterol, colonoscopy, wellness exams. We'll see a spike in that coming up in the next few months. Everybody wants to get those done before the cutoff. Your mammograms, your pap smears for the lower age bracket, 21 to 29. You're about half, and then over 30. Any questions on that? All right. Okay, we're going to jump in a little bit here, and this is your RX summary. So a lot of times plans are seeing an uptick in their spending in RX, and that again is due to specialty medications. That's due to medications that we see on commercials. They're the expensive ones. And so we'll touch base on this. There's a lot of slides on your RX. So I'll just kind of go through a couple of them here. So your RX plan paid per member per month is about $121. You're about 10.38% above our benchmark. Your RX total plan paid right now is $793,000. You're up about 18, I'm sorry, not benchmark. You're up about 18% this time last year. Okay. So you do see that coming through. And right here, you can see reporting as far as your 90-day supply scripts. And we're going to get down here to your top 5 drugs. Again, it's Mounjaro. Those are your most expensive. That's your most utilized as far as cost. And this right here will tell you your comparison. This will tell you exactly what your plan is paying. Then Ozempic, Jardiance, Calquence. These are specialty medications. These are medications that cost the plan. Your top diagnosis is your diabetic therapies. Again, and then you'll see all your other medications, miscellaneous, stuff like this. So this does break this out so you can see exactly where your spend is. There we go. Again, your top 20 drugs in our comparison, when we look at this, you're going to see your Mounjaro is up. So comparison to last year, you're significantly up in the Mounjaro. It could be you've got more members on the plan. Obviously, they do have to have the diagnosis in order to get this medication. There's no generic. So when we look at the medications that hit your plan, when there's no generic, there's a bigger cost. And these are your top drugs. This is telling you exactly where you're spending the majority of your money and who is how many members you have on it. I'm gonna skip that one.
Can I ask a question?
Yeah, absolutely.
If we have 70 people or 72 diagnosed with diabetic, why would we have 111 Am I just not thinking about it right? Why would we have 111 people on Manjaro if it can't be used for weight loss or anything?
Well, let's.
It's just how many scripts were written, not how many claims.
Yeah, I don't think there were that many members, Linda.
Okay.
Yep. So there'd be prescriptions. Yes. Thank you.
Okay. Thanks.
Prescriptions written. Okay. There's a lot in here. So if you guys see something that you want, so we're going to look at our utilization, just comparing. So this compares this time period to last time period. You can definitely see your RX count is up. You're going to see your increase of 4.35%. Total membership, again, you're up members. Therefore, you're going to have an increase in your RX cost. Plan paid last year at this time was 680,000. Plan paid this year is about 800,000. Top utilized pharmacies, you've got Kroger here, and I can't make this any bigger. I looked earlier, so I can't see where it's at. You've got Kroger, Kroger, St. E's. Specialty pharmacy is a large spend there because that's going to be like your oncology, your chemotherapy drugs. So yeah, I can't pull it up. I'm sorry, any bigger. So we do like to we like to see people utilize Kroger pharmacies. They do tend to be a tad bit less expensive than some of the others. We no longer can advise groups to not go to Walgreens or CVS. That used to be something that we would kind of guide groups. We can no longer do that. That was a mandate.
You no longer do that.
It was a mandate. It's
a Kentucky state mandate.
Yeah.
So you can't recommend that our users not go to a certain pharmacy.
You can recommend it, Mayor. You just can't
exclude,
have a lower copay or exclude a pharmacy or something like that that actually hits them in the pocketbook.
So like Walgreens here in Carrollton went out of business a couple of years ago. I know a lot of them did, but before they went out of business, they were more expensive than anybody else, quite frankly, by a lot. And we encouraged our employees to not go there. We can't make you not go there, but we can encourage you to not go there and explain to you why.
Sure. You can definitely encourage and educate.
Yep. So, okay.
Yeah, we just can't. So we just had this come up in another group yesterday that they wanted us to create a flyer for their groups so that they basically just calling out Walgreens and CVS and saying, hey, you can't go there. We can't do that any longer.
No, that makes sense.
Yeah. So, I mean, we can always recommend it, but we can't call those out anymore, and we couldn't exclude it. So we had to stop
it. It's a lot better also for each one of us to have that conversation at home on a local level with our own employees than any of you doing that as well.
Yeah. And you know what? I can get you what we're working on, kind of a flyer. It's like, save your prescription, save on your prescription costs. It saves the plan and it saves the members. So that's something we can look at getting over to as well.
Well, so what I used to tell them is it saves the plan money. You still need to get what you need, right?
Yeah,
but
absolutely.
You can get it and you got what you need. If you can save the plan money, you save the city premiums. That may help your raise someday. I mean, that's the way
Yeah.
Okay.
Yeah. I mean, that's exactly right. I mean, we see this all the time. People utilize pharmacies that cost a lot more. I mean, anything we can do to save on plan costs, ends up benefiting the employees.
Perfect.
So, yeah. All right. So I'm going to stop here. Unless, Lisa, do you want to touch on any of this? I know our time. I mean, this is a lot. I know we only have
is this the first page of this report? This is
the
claim surveillance. So there's a company called Avande, and what Avande is a group of physicians, And that group of physicians scrubs claims on a daily basis. And wherever they identify a claim that might have some potential savings, either because it's a duplicate or something was done that was not medically necessary, they'll try to get some savings for the plan through various means. And sometimes it's a bigger amount, and in those cases they'll come to the plan and say, how do you want to handle this? But on small dollar things, it kind of happens automatically. So they've saved the plan so far this year about $7,800 just on the daily scrubbing of the claims. So
all right, and here's your monthly claims report. This just summarizes everything. Did you want to talk on this, Lisa?
No, I think we're good.
Okay.
I think we need to.
All right, that kind of wraps it up. Again, this is a long presentation, so I kind of went through it quickly. If you have any questions, please let me know. I'm your guys' account manager, so I work really closely with the group. If you have questions, let me know. You can always go through Lisa. I work with Craig on a lot of stuff, so if you guys have any questions, just let me know.
Anybody have any other questions? All right. Next item on the agenda is the administrative renewal. I assume that's the MedBin administrative renewal.
Yes, and I can summarize that. Let me see if I can pull it up. Okay, can everybody see that?
Yes.
Okay. So this is a breakdown of MedBen's fees, and all this flows through Jefferson Health Plan now, comes out of that account. Their base administrative fee is going from $36.35 to $38.15, so a little increase there. MedWatch is your utilization review vendor. They do your pre-certs, they do case management for anybody who's a large claimant and needs assistance through case management. Your integrations staying the same. MedBen RX is going up by a quarter. The BPP, that's the Benefit Preservation Program, that is your specialty drug program where MedBen tries to source specialty drugs whenever possible through the manufacturer's patient assistance programs or through coupons that are available to the plan. And we try to keep specialty drugs off the plan whenever possible. And if we can't keep them off, then we get them at the lowest possible price point. Rescribe is the program that we put in sometime during the course of this plan year. Initially, the fees for that were waived, and going forward, it'll be $1 per pharmacy claim. That is the personal importation program where non-specialty brands are coming, and possibly specialty brands if that's the lowest price point for a specialty drug, through Canada at no cost to the member and at a greatly reduced cost to the plan. COBRA administration staying the same. Medicare Part D services, no change there. Well Living's the same. There's a change in the Zealous open access pricing. They're your reference-based pricing vendor. So for plans 9, 10, and 11, they do the repricing for the claims coming through those plans, meaning they apply the discounts. And they also do any negotiations that are needed for balanced bills. We don't have a lot of balanced bills that come through those plans, but when we do, they do those negotiations. So their fees are going up by 50 cents. Reference-based pricing contracting fee, that's for the services of Employer Advisory Services, EAS. That's a subsidiary of Cheryl Morgan. EAS negotiates contracts with different hospital systems, including St. Elizabeth, and that fee is going up by 50 cents. The broker fee staying the same. Stop loss coordination fee, that's staying the same. So all told, The per employee per month fee would go from $93.45 to $97.10, which is an increase of 3.9%. Any questions? All right.
Okay, if there's no questions, just to keep everything above board, I guess I will entertain a motion to accept this renewal proposal.
So moved.
Okay, thank you, Harry. Is there a second?
Second.
I heard somebody. I think it was.
I did.
All right, Peggy, thank you. Any other questions or discussion? Hearing none, all in favor, please say aye. Aye.
Aye.
Aye. Any opposed? Okay. Next up is the Jefferson Health Plan renewal.
All right. Can everybody see the JHP renewal here?
Yes.
Okay. So in response to the board's request after the March meeting to make a lump sum contribution to the JHP account that would not only fulfill what they were asking from the plan in the form of a reserve contribution, but also erase the deficit that would have remained in the account after that payment was made. So for a total lump sum contribution of $181,000, that gets the renewal down to 6.5%. So the rates for all the plans will go up by 6.5%. $181,000 would come out of the legacy reserve. And I think that's all I need to say about that. Any questions?
Yes, I have one because there's a note in red right underneath that says a lump sum of $90,500, which was their original ask. You know, they were
Yes.
originally going to break that 81,000 in half, 181,000 in half, and you know, make that contribution. So I'm totally fine because the board wanted to make the full 181 donation or contribute shift over to their funds, but it looks like they're only asking for 90.50. Can we get clarification?
Well, that was what they originally requested, which was half of the projected deficit in the reserve, but the board wanted to not run that deficit.
Right.
Right, but if you're saying 6.5% and they're still showing the 95 on here, and we make the 181, is that now 6%?
No, it's 6.5. The 6.5 was just for projected claims and
I know.
for next year and so forth. So that you can see here, there's no additional funding required for the reserve. It's a 0%. Previously, it was a 1 point something, I believe.
So out of the 181,000, then is that all? It's going to be all legacy reserve that will go into JHP?
Correct.
And so, I mean, we're technically not buying down that percentage increase, correct?
No, you did
We're
because
just
it was originally
9.33,
I believe.
correct, but that was including like there was a certain amount that was going to be a premium increase that would, I guess, cover medical inflation, correct, and cost for JHP. That's going to go to JHP as our stop loss. But the remainder of that was going to be our reserve, like our legacy reserve. That was, I guess, going to be, I guess it's earmarked now is our reserve within JHP.
Yeah, it's going into your reserve account within JHP, and it'll be essentially zero will be in that reserve account. But you were going to have a negative balance.
Right. They were going to add an extra $90,000 to all of our premiums, spread it out amongst all of us. But in each month, they were going to add an extra a couple percentage to our renewal in order to claw back that money. And was not going to build up the reserves because they were basically fronting us the money. And that was a part of the agreement when we joined them, was that in exchange for getting their stop loss coverage in the future years. If we did run a deficit, they would take it back over a couple of years.
Sure. So out of the 181,000 we're taking out of their legacy reserve and it's going to the JHP, how much of that is going to be part of our reserves?
181.
So it's all going to be our reserves.
Yes.
Okay.
I have a question, and I apologize for missing the March meeting. I was out of town, out of state, and didn't have phone service. But how does what we're talking about now play into the next agenda item as far as recommendation and what we're going to pay Jefferson Health Plan? And I know it's all part to build up the reserve so we can get our contributions out of our budgets lower. And then how does that play into if we have this 2 million and some dollars in this account and we just chose to send 1.5 million to put in CDs or whatever, how much is left? And if that money really at this point has no purpose anymore other than it was in our reserves, why do we not send more over to Jefferson Health Plan and invest it there, and like we used to invest it ourselves, and keep our premiums low and build that reserve? Does that make any sense at all?
Well, if we were to send more money to Jefferson Health, we're not investing there. We wouldn't be making nothing off of that. The 181,000 that we were paying now, from my understanding, makes us whole as far as our reserves with Jefferson Health. The additional $2 million that we have, well, actually, it's going to be less than that after we pay the 181. But just for conversation, $2 million is our reserves from our original pool. If we were to ever pull out of Jefferson Health, that's going to be our reserves to be able to pay runouts.
Yep.
But if we would leave Jefferson, that $181,000 that we're going to give this year, we would be able to take that, correct?
No, I think that is covering
Cover the running
stop loss from this year.
But
right.
if you do have a positive reserve at whatever point in time you would leave JHP, then yes, that reserve belongs to you.
Yes.
First, you have to pay your runout claims out of it, and then
of course,
distributed. Yeah.
Oh, I understand. I'm just trying to get straight in my head, because before we would have a number come in like this 6.5% would more than likely be an increase in premiums, and that would go to our stop loss carrier, right? But now that JHP's stop loss, they're going to be covering that. And then we would also, whatever our additional premium increase would be, that would go into our like legacy reserve. But now there's a
well, this 6.5% is not just stop loss. It's everything. It's the claims. It's the administrative fees. It's the stop loss premiums. It's all the funding.
Okay.
Except for the reserve, which you're doing through the lump sum contribution.
Right. So think back all the way back when we first got started, that first year when we, after the first renewal, we would bank like $100,000, $200,000 a year, and we would just slowly build up that reserve from zero. Well, we're essentially doing the same thing again with Jefferson Health Plan.
Sure.
The only good news for us is that we have our legacy reserves hanging in the backdrop, which allows us to do something that we would never have been able to have done back when we first got started, which is make up the deficit out of year one, and give ourselves a running shot to start building that reserve, which right now we would not. If we were in this exact same situation in 2015, we would be sending everybody a bill for the makeup to make up the 181 difference. Because we need the money. This year, we don't have to do that because JHP is floating us. But we as a board decided we don't want to be floated. So we're going to go ahead and make it up because we can, and that legacy reserve that's there is there for two reasons in my head. One is to provide us the funding we need to pay for our own board expenses, through investment dollars. But then the other reason it's there is it gives us a huge opportunity that if we really want to walk away from JHP, we can, because we can just start right back up where we were, as far as having that balance, and be able to cash flow everything. So I think that's the two reasons for that legacy reserve.
So we also discussed paying off the deficit, the 181,000, and then also looked at some numbers of if we were going to decide if it was going to be 6.5 or 5.5, adding more money from our reserve to that to buy the premiums down. Where did we ever land on that?
Last board discussion was to go for 6.5.
Yes.
Oh, we voted at 6.5 because I thought we had just discussed some numbers but never actually voted on to go to 6.5.
I think we're voting today on that. I think that's part of our discussion, in accepting this, because Jefferson Health Plan had sent us a proposal that was going to be 933.
Yeah.
We kicked around numbers and we were like, no, let's make it 6.5, and then this is Jefferson's proposal back to us at 6.5.
Yeah.
So I think that leads me, I think that's exactly what I'm trying to ask, what I was trying to get to in my original question is the 181,000, is that only this year's contribution to build up the pot over a few years?
It is meant to keep us from starting below ground. It's
Okay.
meant to keep us starting below zero.
So, I did get briefed after the last meeting that I missed. So what I was thinking is, the more if we only pay 181 and we save the rest of our money and we put it over in the bank, the pot is making money drawing interest, but we are having to pay. While 6.5 is better than 933, we're still having to pay 6% out of the budget. Would it make sense to transfer more of that money and build our, maybe in year one, we pay enough for where they would want us in year three and cost us less than our budgets? Does that make sense?
Are you talking
Well,
about
the 181 is for 2 years. It was $90,500 for this year, $90,500 for next year to get us basically even with our reserves. The 6.5% increase is basically the increase that we're facing for claims and RX and administrative fees.
So like medical inflation, correct?
Correct.
So it's not because our pot is not built up. If we paid more money and built the pot up, we still have these increases.
Correct. I think so.
Okay, then I think that answers my question. You see where I'm going? I'm wanting to, if we got the money, pay it now and not pay an increase in our budget. But if paying more now doesn't eliminate that, it's a moot point.
Right, exactly.
Okay. Just a reminder, we took a zero, to where we are. So, we got to make that up eventually. We can't take zeros every year.
True. I mean, we did take a zero, but I think we could have taken a cut that year as well. So I understand we're constantly being conservative. I'm trying to make sure that it's, I guess, square in my head as far as like where this money is going. So the 181,000 is it's going to be a part of our reserve that we could, technically have access to. But if we pay any over that and pay down that 6.5%, then that's going directly to Jefferson Health, and it's like paying down our stop loss premium, correct? And basically, we're not going to see that money come back.
Right.
So,
exactly.
I understand we're trying to be conservative, and then we can see how our reserves, the legacy reserves, look after that.
Yes.
After this next year, correct, and see what we can make, and then perhaps next year, since we don't have to worry about funding our reserve, right, because we're doing it this year, then we can look
it'll be built into it'll be built into our premiums after that. Correct.
Okay.
Yes.
And then we can look at possibly seeing what we make off our legacy reserves to buy down whatever the percentage is for the next year. Is that, am I looking at that correctly?
Yes.
Yes.
So one question I would have, and I know it's probably gonna look a little forward here as far as, getting different groups in, but our legacy reserve is now, obviously, we have access to that, just this group. But once it goes into Jefferson Health and goes into that reserve, is that now opened up to like whoever is part of our group?
Yes, if the group expand, then new members would have access to the JHP reserve because they would be members of that group.
Okay.
But not the legacy.
Right.
Well, not the legacy, but I mean, over the years, it's I guess eventually going to go to JHP, right? Because right now they're looking at a 1.2, if I'm looking at this right, the $1.2 million recommended fully reserved account. So, we'll eventually put that money over into JHP for our reserve.
Right. And if we have a positive reserve and we decide to leave, that positive reserve is for the run out and for our group.
Sure.
Which
Sure,
would
but yeah,
include new members.
so I'm just looking that we would have the legacy group and then we'd have
A new
whatever other
group.
part of that group too, right?
Yeah,
Right.
expanded group. Yeah.
Okay.
Yeah, and the goal
Mr.
is
Chairman?
we would grow to that $1.2 million mark over the next several years.
Correct.
Oh, sure.
So to ask my question one more time, just to make sure I'm clear, if we took this $1 million and paid that today, we would still have an increase of 6%.
Correct.
Okay, that's all I want. You see where I was going there, so that's all I want.
Absolutely.
I got my questions answered.
Mr. Chairman, you need a motion to approve.
I do if there's no other discussion or questions. I don't want to kill, anybody's opportunity to ask questions and make sure everybody understands it before we vote. But yes, I can entertain that motion.
So moved.
Right.
I'll second.
Okay. And the second was
Joby.
Okay. Great. Motion made by Harry, second by Joby. Any other questions or discussion to accept the 6.5% renewal and premium increase for our health plan? Okay. Hearing none, all in favor, please say aye. Aye.
Aye.
Any opposed? All right.
Mr. Chairman, I have another meeting I need to get to here in about 5 minutes. If I drop off here in a minute, you still have a quorum, right?
As far as I know.
Yes.
Okay.
All right. Next item real quick is the plan design recommendations.
Okay. Can everybody see that page?
Yes.
Okay. So on the health plan side, we heard some data regarding ER utilization. And one thing that we didn't touch on is that emergency room utilization overall was up 25%. And some of that is due to the increase in membership. But it's been a while since we made any plan design changes to copays. And we're recommending that to try to stem some of that increase in utilization at the ER, that all plans that have copays have an increase of $50. Plan 1 and Plan 5, I believe, have a $200 ER copay currently. And plans 9, 10, Plan 9 has a $250, Plan 10 is a $300, Plan 11, which nobody's using, has a $350 copay. So increasing all of those by $50 is our recommendation. And then, Mr. Chairman, do you want me to stop after each one or do them all?
Let's just run through them all real quick and then we can do questions.
Okay. The second one is to increase the out-of-pocket maximums on plans 9, 10, and 11 to the federal maximum of $10,600 single and double that for family. It's almost impossible to hit those out-of-pockets with the copay plans that you have, so it's really not going to impact Anybody? I mean, maybe one or two people in the history of the plan have ever hit the out-of-pocket maximum on those copay plans. The third one is to increase the deductibles on Plan 6, which is your qualified high deductible health plan, to what the IRS requires them to be for 2026. And so that would be an increase of $50 on the single, going to $1,700, and then $100 on the family, so $3,400 there. And then on the pharmacy side, this is not a, it's just a change to have the plan documents reflect what's actually happening in practice, which is that high cost generics fall into tier 2 rather than tier 1 on both pharmacy plans. Any questions?
So to go back on the the copays, what plans was it? 200?
Plans 1 and 5.
Okay.
I'm not sure if we even have anyone on plan 1 currently.
But those plans have deductibles.
They do have deductibles.
Yeah.
Right.
Yeah.
So
You
is
do
the
not currently have anyone on plan 1.
No one's on plan 1. Okay.
Correct.
So
Is the
plan
rec-
5, the ER copay is 200.
Yes.
I mean, you may not have this information in front of you, but of the ER claims, how many were on plan 5?
That is a good question, and Amber will have to do some research on that, I'm sure.
Yep, I can pull that.
Okay.
Was my question is, so if we're trying to essentially make people use the ER more for emergency uses, is that the reason why we're looking at a $50 increase?
Yes.
So if more of those people are on plan 5 that use that, what I don't want to do is affect the people that do use it as an emergency just because of the few that don't.
Mm-hmm.
Right. And that's why I asked that question, Joe, because if it's in fact that, you know, half the people are on plan 5 and they're only paying $200, and then let's bump theirs to 250. And, you know, those that are on plan 9, it's already $250. I mean, I don't know about everybody else, but $250 kind of deters me from going to the emergency room.
Absolutely. And as far as just, I know we saw the report on the ER and like the multiple visits and things. I mean, do you see that a tactic of increasing it by $50? Does that steer people away, or
Yeah.
would there be another tactic that we could use as far as in that, like as far as education, or again, I'm not sure. You know,
Yeah.
it's
You can
sometimes
always educate, but really, I mean, until you start imposing some kind of financial incentive, you know, people are just only so motivated by education.
Sure.
And it's really not about collecting those extra copays. It's really about steering people to the right, to the best value place.
Right.
For,
And but then
you don't have a lot of people on plan 5. It's probably plan 9. That's where the majority of your members are. That's probably where most of those ER visits came from.
And I will say that compared to the other copays that are available from the Anthems and the Humanas of the world, not Humanas, United Healthcares of the world, $250 or even $300 is below what you typically see out there in today's world.
Right. And no, and I agree with that. I mean, I can remember before we started this group, I think our copay back in 2012, if you went to the emergency room, was $500 back then.
Yeah. A lot of plans now have deductible and coinsurance on it, plus a copay for
right.
You know what I didn't hear is that the folks that are using the ER, do they have options to use urgent care? So what I'm thinking is it possible these people are, the folks that are using the ER, do they live possibly in a rural area and an ER is their only option?
Right. And not only that, but you know, we've had some additional folks come on this year. So is this just an odd year? that we had these other folks coming on, and is it a combination of, are they rural and really the only thing they have is an ER?
I could try to pull some demographics in our analytics system and see if we can break that out a little bit to see. And you could be right. That could be what it is. You know, we're just seeing an uptick in your members and then their locations. So I can see if we can pull something by like locations and see if we can maybe boil that down a little bit.
I guess the bottom line too is this $50 increase seems pretty nominal. And I'm guessing that, you know, as this is being presented to the members, that they're going to be presented with the options that they have to reduce their ER costs as individuals. So
I think what happens is when we increase an ER copay or anything like that, it brings that to the top of the plan again.
Yeah.
So everybody notices that. So they're like, oh, you know, so because right now it's, you know, it's down in the plan language, no one's really paying attention to it, brings that back up to the, you know, to the front of the room again. And everybody sees that and says, oh, boy, that is $250. Or, you know, so I think that's what we see happen, Lisa. I think you probably agree on that's how we see that work.
Yeah.
But if I could break this down by location, that would be great. I'll see what I can pull and then share that information to everybody so they can see.
Okay. I have a question on a different section. If everybody's ready to move on off of the ER. What is the definition of a high cost generic? Where's that cut off? Where we start treating them like brand?
Amber, is there a specific dollar amount?
There is not, no. So there is not a specific dollar amount that you guys cut off or that is like it's just a cutoff. So basically, and I'm trying to think like a high cost generic. I'm going to say like, these are the ones, again, these are the ones, they don't always have to be a specialist. So let's say, when we talk about RX and drug costs, we're like, well, we know the ones that we see on TV are going to be really expensive. That doesn't mean that they're always a specialty drug though. So you've got your high cost generic versus your specialty. Your specialty medications are a totally different tier. And then your high cost generic drugs, they're labeled high cost generics. But there's no dollar amount on that. We could set one. I mean, there's, you know, there's different options, but basically a high cost generic versus your specialty.
Right. So for the new, we call it the new pharmacy plan that we adopted several years ago, where everybody just went to a straight percentage of copay for the drug cost. That's not a problem, right? You know, if it's a higher cost drug, you pay a little bit more at the pharmacy.
Right.
But I still have employees who still are on the old tiered plan. So having a drug labeled generic versus brand would be a cost difference to them. And I'm just trying to understand what criteria do we use to make that crossover?
Well, they should already be paying the higher copay. It's just that the plan documents have they have not been consistent in how they describe the copays. So instead of saying tier 1, tier 2, tier 3, they say generic. And then if a drug is a high cost generic, it's not actually falling into that generic tier, it's falling into tier 2. So we're just trying to clean up the plan language so that people they're not getting caught off guard and saying, oh, hey, this is a generic drug. What do you mean it's not $5? Yeah.
So Lisa, basically what you're saying is, the way I take it is we're already doing this.
Yes.
We just need to clear the language up.
Exactly.
Correct.
It's not really even a plan change. It's just it's going to require a plan amendment.
Yeah.
But it's just to make the plan accurately reflect what is currently happening.
Gotcha.
Thank you for clearing that up, because I was confused as well.
Yeah.
But you're saying that the high cost generics drugs, they're already in tier 2.
Yes.
Correct.
And we've had a couple of situations over the last year or two where people have, been confused by that. So we want to make sure that we get this straight in the plan.
So if someone's paying the extra premium for their option A, it'll still be that $30 copay. And if
Right.
they're not,
Correct.
they're going to be paying that 25%, but it's not going to change what they're currently doing, correct?
Right.
Correct. Correct.
Thank you for that.
Mm-hmm.
So based on the discussion regarding, ER fees and the fact that we need to get a little bit more information in detail, I will politely ask our secretary to make sure that this item gets added to our June agenda, so that we can then vote for final passage of these plan changes and get that taken care of. Does that work, Lisa?
Well, the only thing I'm concerned about is groups who are doing enrollment meetings, and we need to prepare the materials and educate people to what the copays are going to be. If we don't know that until mid-June, that could be a problem.
Okay, that would be a problem.
Yeah.
So what's the
We
board's
can table it until next year, or
or accept everything except the ER copays?
yeah, or we could even just change plans 1 and 5 to bring them up to 250 where plan 9 is. That might be kind of a middle of the road approach.
I would be okay with that.
That is the Kentucky benchmark currently, 250.
And then perhaps if, I know that Joe would typically come out and do an educational thing, and I understand education's only going to go so far, but if perhaps there could be something very specific in there about ER visits.
Yeah.
And just the cost, not only the cost to the plan, but also the cost to the individual, comparing, say, a urgent care visit or a primary care visit to an ER visit.
Sure.
But yeah, if all plans are on the same, and then next year if we increase by 50, then it's going to be across the board, as opposed to just, it'd be different for different people. And yeah, I'd be fine with, increasing the other two, I guess, plans to 250 across the board.
Okay. All right, so I'm going to take that as a motion. I'm going to summarize it by saying that we will accept the plan design recommendations, except that the ER copay increase is only impacting Plan 1 and Plan 5. Is that correct?
Correct.
All right. And so I have, I'm going to assume I have a motion to that effect.
Yes.
Okay. And is there a second?
I'll second.
All right. Motion made and seconded. Any other discussion? Okay. Hearing none, all in favor, please say aye.
Aye.
Any opposed? Okay. Great. Last item on the agenda is an interlocal agreement draft. So as you know, Jefferson Health Plan came into Kentucky with us. They also had the city of Newport. So right now, I believe we're basically the two members of the Northern Kentucky Jefferson Health Plan group at this time. And they are really interested in adding new members. And they want to add new members to our group. Because we have that capability of doing that. At the time, we were discussing with JHP coming on board or switching to them for stop loss. We were also renewing our interlocal agreement, and there was not a clear consensus that we were going to go to JHP, but we had to get the new interlocal done, so we two-tracked it. And so the interlocal agreement we all adopted last year did not have any language about adding members, new members to the group, or adding new members outside of the ad district. So there is a draft interlocal agreement amendment that would do two things, basically. One is it would allow us to add members outside of the Northern Kentucky Area Development District area to our group in what we're calling the extended pool. And they would be straight JHP members. Whatever JHP came up with, that's what they're going to pay. There's no discussion on that. That's their renewals. Then we create inside the interlocal agreement the legacy pool, which is all of us. And the only difference is the legacy pool members have access to the legacy reserve. The new members would not. Our interlocal does allow for Northern Kentucky Area Development District agencies, so anybody in the 8 counties, to join the board and buy in. And that's how we've been treating new members for the last decade. And this interlocal would kind of codify that and allow that if and I'm just going to make up a jurisdiction. We're going to say City of Alexandria wants to join, and City of Alexandria wants to join, and they want to do the buy-in. They can pay us the buy-in, and they can join the legacy pool. If a Bullock Penn Water District wanted to join, because they've showed interest in the past, but they don't want to do the buy-in, they would just join the extended pool, and they would just be faced with whatever the straight JHP renewals would be. And so, and of course, if anybody else outside of the Northern Kentucky Area Development District, let's say Sadieville wanted to join, right? They're down in Scott County. They would automatically be JHP extended pool. They would not be able to join the legacy group, even if they wanted to. So those are the only changes. There is one text change that Cheryl Morgan's crew discovered in the old language. Section 3.1 has a parentheses set that talks about original members. We just need to strike that parentheses set. That it doesn't change anything with that with the language in that clause, and we don't really talk about original members anywhere else in the document. So that's just removing that line, and we'll get updated information on that, updated draft out. But would like for each of you to go back to your all's jurisdictions and start the process of adopting the amendment so that we can start adding members outside of Northern Kentucky and allowing and at the same time protecting our legacy reserve for those of us who have put in over the last decade or who have bought in when they came in to the group. Does that make sense? And does anybody have any questions?
Perfect sense.
Did this expire last year? Is why we're doing dated 25 instead of 26?
No, that was actually a typo from the other one, in that the agreement that Brian Diener and everybody worked up and Lori Zombach worked up back in 2014 was an 11-year agreement, and somehow my city attorney didn't catch that, so that just corrects that.
So we're going from 25 to 35.
Right.
Gotcha.
Yeah.
Okay.
Yeah, because we just started this new interlocal this past July.
So as far as adding new members outside of the Northern Kentucky area, logistically, I mean, how's that going to work? Because again, just as far as having other groups, I know when the inception of our group here, there was a lot of groundwork that needed to be done as far as creating relationships with providers, contracts. So are we looking at the entire state of Kentucky? So we could pull from Bowling Green or Paducah or, out of Eastern Kentucky or, wherever it may be. So anywhere in the state, and how big would these entities be? I mean, or were they just looking for the smaller entities, or is this open to anyone?
It's open to anyone, but I tend to think that it's going to be groups that are under the 100 employee mark or somewhere around there. Those groups tend to be ones that are looking for the value of pooling with other entities. If you have a 800 person group, they may want to be on their own, self-funded.
So, right. And I mean, as far as the need for us to take on the other groups, I mean, again, we'd have the legacy or the Northern Kentucky group, and then this extended pool. I mean, what would stop now that JHP has an established, in Kentucky, if they just, if they started to market themselves throughout the state and just pull a bunch of smaller entities together, sort of like us. I mean, our group, we happened to be in the Northern Kentucky group, but we were all looking for the same thing, and we came together and just created a group. So what, I mean, is there something in the language or something in, the legislation that, entities couldn't do that as far as like just pulling together with JHP being the, their, I guess, anchor, if you will, as far as their pool and stop loss carrier?
Well, that's basically JHP is looking to utilize this group as their way to add members. So they wouldn't be going out and creating separate pools, if that's what you're thinking.
Yeah, JHP will not take groups under 50. It just, straight into their pool as independent entities. So you guys are the best vehicle for getting the smaller groups.
Right. So again, just making up an entity. If another entity like City of Erlanger wanted to join JHP, they're big enough to do that straight, just like Newport did. Right.
Just like Newport did.
Right. But smaller groups would probably be directed towards.
Correct.
And as you may recall, one of the things that we talked about was getting to a larger group as an entity, as the NKPE entity itself, that smooths out the curves or smooths out the spikes in terms of claims and things like that. The more people you have to absorb that across, the less dramatic your increases tend to be, simply because you're spreading it across more people.
Yeah. Yeah. I understand that that's kind of been the thought. But I also, I mean, in the reports that we had, it said we had an increase in membership, so we've had an increase in claims. So, I mean, that I'm just be afraid that it would swing the other way of where, our premiums, I know we have some control because we have that legacy, but again, JHP will ultimately dictate what that increase is, and then we would have to decide on whether, it's a buy down or not. With our legacy amount.
Yeah,
So,
new groups are going to go through underwriting just as they always have. So Jefferson Health Plan and their umbrella stop loss carrier will be vetting all of the potential new groups, and the board will ultimately get to decide if you want to accept a new group or not. So it's not like we're just going to take everybody. We're going to have to, assess whether or not they're a good risk. And then,
Okay.
that's not a perfect science. You could still pick up high claimants in that process, but we do what we can to make
Sure.
sure that we're not bringing bad risk into the pool.
And if you add, 80 people to the pool, your total claims certainly will go up. There's no denying that. It's just a matter of does the per employee per year claim amount go up or not?
Right, because you're funding more into the plan too for all those additional bodies. So, ideally your funding is appropriate, to accommodate those additional claims.
Is that typically what you see though? I mean, obviously the more people, the less the premiums could go up because of claims, more money coming in, but it still affects the bottom dollar better.
Yes. I mean, a bigger risk pool is going to, as Mike said, have a smoothing effect. You're going to have fewer peaks and valleys, and there are also economies of scale that you obtain when you have a bigger pool. Stop loss, administrative fees generally tend to cost less when you have more people in your plan.
Right. So,
do you have experience with a group having this situation, like in other states?
Does Jefferson Health Plan have experience doing this in other states? Yes, they certainly do. At
Well,
least
kind of like, with our situation, and that we've got like a geographic group, and then it would extend out to, the borders would be extended out, instead of the Northern Kentucky area, now we potentially go statewide.
Yeah, they have other sub pools that they have within Jefferson Health Plan that are regional.
That's essentially how they got started.
Yeah.
Yeah, I was on their membership meeting yesterday, and they talked, extensively about Ohio because they're almost everybody they have is in Ohio. But then they also briefly talked about the Ohio Valley pool. So that was a subset of the Ohio group. So yeah, they've done this before.
And I take it with success, correct? I mean, again,
Yeah.
the bigger the pool, the more success.
Yeah, properly managed and properly underwritten. Sorry.
My only concern would be as the pool gets bigger, as our overall funding and numbers go up, that there's a chance that our uh, fiduciary bond might increase, and maybe even our directors and officers insurance. And so, there would have to be some discussion with JHP about making sure extended pool members were contributing back to us for something along those lines. And that's not going to be a lot of dollars, but it's going to be something.
Oh, for sure. The administrative side of everything it would have to be commensurate with new groups,
So maybe there would be a per member per month fee for us. I mean, a tiny one, but it would still be there.
So people in the extended pool would get a place on this board.
I'm sorry, Terry, I missed that.
I said people in the extended pool would have a vote.
Yes,
Okay.
they would have a vote in the overall board, the overall plan designs, overall changes that we would make, just like we all do. They would also have the ability to create their own plans, just like we all do. The only thing they would not have access to is the legacy account.
How does that work if we say buy down our premiums? They don't have a vote in that, I guess.
No, and they don't get access to it. So if we had somebody who was a part of the extended pool right now, they would be paying 933, and that would just be the way it is.
Yeah.
So, but we talked about the reserve that then goes to JHP, that 181,000 that we're transferring. Then ultimately, would that become the entire group's pool?
If there was a balance that, if there was a balance in that, yes, it would be the entire group's. But right now we're running a deficit, so that's why we're plugging in 181.
Understand, but over time, it's more than likely going to build.
Yeah, over time it'll grow up, right? Yeah, we had a bad first year, basically, in JHP's world.
Grow
Paul,
fast,
to your point,
more people too.
Yes,
essentially the JHP reserve.
Yeah.
Okay. Any other questions on the interlocal agreement and what we're attempting to do with this? If anybody has any concerns about this, or you talk to your leadership and they have concerns, please bring them back. I mean, we want to, first off, we want to be honest with JHP, with where we are as a group, about what we're doing. But also, let's be honest, is like when JHP looked to bring us on with very favorable terms, this was the payoff for them. The payoff for us was we got access to them as our stop loss, and access to that money, which we're using right now because we're 181,000 in the hole with them for the year. But the payoff for that on their side is they would use us as a vehicle to expand into Kentucky.
Yeah, no, I'm good with it.
What do you need to see at the end of the day, Craig, from each member? You need us to all sign it. You need
so if you are right, so if so go talk to your legal staff. I know some cities and counties prefer interlocals to be by ordinance. Some prefer them to be by order or resolution. I'll leave it up to each individual jurisdiction to figure out how to do that. If you are a special district, you only need to put that in front of your board once, and vote on that as I guess like a resolution.
Yep.
Okay.
And then, of course, everybody would need to send copies to Courtney, so that they can make sure all those are copies there. And I did see the chat note pop up. I guess that typo that was in the draft I had from my city attorney was corrected before it went out to get filed. So that was good. Any other questions?
Nope.
Okay. All right. I guess the next item on the agenda would be announcements and reminders. So we do have a June meeting. That's the meeting that we had approved the budget. That is typically our in-person meeting at the ad district. And I just don't have the date sitting in front of me. I should, but I don't.
June 12th.
June 12th. All right.
And just a reminder that at that meeting, we will have someone from Jefferson Health Plan there to review the billing process, which we're trying to streamline and simplify.
Cool. I feel for him. So, all right. Anybody else have anything you want to discuss? Any other items?
Yeah, Mr. Chairman, can we go back to Heritage Bank investments? Do we need a motion to go ahead and approve signers for that?
It wouldn't hurt.
Yeah, so Tom sent me an email whenever he logged out and thanking us for the opportunity. But he also said he can get everything set up on our schedule, just need information as far as who's the authorized individuals that are going to be the signers and their personal information, as well as, you know, our EIN number and so forth. So I thought that it might be prudent to go ahead and approve some signers for that.
Okay, that'd be great. So I'm signer on everything, so I guess I'm on that list.
I'm a signer on something.
Yeah, you're the signer on the HRA account. And you've done the contacts, so I'd have no problem with you being the signers on the investment portion. And then typically we have the ad district treasurer or finance officer on as well.
Yeah.
So that would give us 3.
Okay.
Okay. Harry, is that a motion?
That's a motion.
Got a
All
second.
right. All right. I heard a second. Terry. So any other discussion or questions? Not all in favor, please say aye. Aye.
Aye.
Any opposed? Okay. All right. Anything else for the good of the order?
The only other thing I would add is that we do have a couple of groups that are interested, and we're going through the process of having underwriting review them. That's Pioneer Fitchburg Fire Protection, Taylor Mill, Lakeside Park, Crestview Hills Police Department. Alexandria has expressed interest. The timing of whether or not they have to do the buy-in is kind of important for them because they have a June renewal, and so we'll see if that how that goes.
Okay. All right. Okay. And thanks for that update. Any other questions? All right. Hearing none, I will entertain a motion to adjourn.
So moved.
Second.
Motion made and seconded. All in favor, please say aye. 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 Thank you all. See you in June.
Thanks, everybody.
See you guys.